So there's a long history of trials of PCI and bypass surgery. And here is a list of the trials over the years that have shown no difference in death or myocardial infarction. 15 trials of bypass surgery versus PTCA, the only exception being the Barry trial. Bare metal stents versus PTCA, 29 trials, no difference in death or myocardial infarction. Bare metal stents versus drug-eluting stents, 11 trials in terms of death or myocardial infarction, no difference. And then bypass surgery versus bare metal stents, 5 trials. One of them, the Barry 2D trial, showed a benefit in favor of bypass surgery in some subsets, not overall, but in some subsets. And then we've had trials of bypass surgery versus drug-eluting stents, and you'll hear more about that. The Syntax trial demonstrating a benefit for surgery in 3-vessel disease and high and intermediate Syntax scores for left main disease. And then the Freedom trial of diabetics. Now, what I really want to focus on this afternoon actually is not so much these trials, but the limitations of trials and registry studies. And Dr. Bax and I were talking about this at lunchtime. And this is from an editorial that I published some time back in the New England Journal, which said, things may not be as they seem. And it was really about the New York registry. And what we pointed out was registry studies, which we use so often, and they are important, they have selection bias, but they have much greater relevance to the practice at large. Randomized trials actually have their own bias. It's what we call entry bias, and that is, remember, to get into a randomized trial, there has to be clinical equipoise. You have to feel that the patient, the inclusion criteria, that the patients are eligible for either PCI or for bypass surgery. And if you feel that they're not, you have no right ethically to randomize the patient. And this is why I think it is very unfair in a way that many of the trials are criticized, like Barry and SOS, because only 5 to 12% of all patients undergoing revascularization at participating institutions were in the trials. And that's probably accurate because in many cases you have a very clear idea whether the patient should have surgery or PCI. And if you do, you shouldn't put them in a trial. Syntax actually, it was the one that included the most patients screened, 41 patients screened. Courage 6.4%, Freedom 10%. It's not a criticism of the trial, it's a fact of life. On the other hand, if you look at registries, they do complement the trials, but they have their own pitfalls, their own problems. First of all registries are subject to confounding variables. And when we do multivariate models to adjust for these differences in baseline variables, we have to understand that the multivariate models statistically adjust, but they don't eliminate the baseline variables. They don't eliminate the differences. They adjust for differences. But a multivariate analysis is not a randomized trial. They each have their strengths and their weaknesses. And then what is not really in the randomized trials are the essence of the clinical assessment, which takes into account age, comorbidities, frailty, which arteries are involved, psychological and social characteristics, patient preferences, and the proficiency of operators. The trial of renal denervation for hypertension, Simplicity 3, was criticized because they felt that operators were inexperienced. So all of these are factors that are absolutely essential to the clinical decision, and they may not be taken into account in trials. And here's a wonderful example of what can happen with a registry. This was a study of statin adherence and the risk of accidents. 141,000 patients in British Columbia who were prescribed statins for primary prevention. And then they were classified according to those who were adherent to their statins and those who were less adherent based upon filling the prescriptions. And if they, on multivariable analysis, if they were adherent to statins, there was a 25% reduction in motor vehicle accidents, a 23% reduction in workplace accidents, a much greater use of screening services like mammography, and a much lower likelihood of developing other diseases that had nothing to do with the biological effect of the statins. So what this taught us was nothing to do about statins. What it taught us is that people that take their drugs are different from those that don't. People who enter into randomized trials are different from those that don't. Now, factors favoring bypass surgery over PCI in patients with multivessel disease and diabetes are shown here. And diabetics have diffuse disease, progressive disease, and chronic total occlusions. And therefore, they should be completely revascularized if possible. PCI, and this is from a paper in article we published in the New England Journal, PCI is directed at a target or targets. Bypass surgery and secondary prevention are not just directed towards the target stenosis, but all these future culprits along the line of the vessel. So PCI is lesion directed. Bypass surgery is vessel directed, as is secondary prevention. And so when we come to the Barry trial, this is one of the classic studies that illustrates the difference between a registry and a randomized trial. This was the randomized trial of PTCA versus bypass surgery. It's many years old now and it's outdated. But what you saw here in terms of 5-year mortality was with PTCA, this is cumulative survival, with PTCA in yellow versus bypass surgery in orange. The difference was 34.5% mortality versus 19.4%. A huge difference in favor of bypass surgery. And then in the Barry trial, there was a registry. And these were patients who were eligible for the trial, but either the patient or the patient's physician said, I'm not going to randomize them. I think this patient should be treated with surgery or with PTCA. And look what happened to the diabetics in the registry. No difference, and they both did better, both groups did better than in the trial. So how do you explain that? Because it's a very powerful phenomenon. What it was, it's not surprising that bypass surgery was superior to PTCA in diabetics. Part of it is the independent effect of diabetes on disease progression and extent. And the fact that disease in diabetics is aggressive and diffuse would favor bypass surgery, which bypasses a vessel and not just a particular stenosis. But the magnitude of the difference in that trial was enhanced by the process of randomization versus clinical judgment. So in the randomized trial, everybody, it was 50-50. You either got bypass surgery or PTCA. But in the registry, the physician and the patient preference took place. And in fact, what it was the sicker patients in the trial who were randomized to PTCA, in real-life clinical practice, they went to bypass surgery. And those who were less sick went to PTCA. And that's why in the registry, there was no difference in survival, whereas there was in the randomized trial. Very, really important principle to understand. Same thing happened with drug-eluting stents. Now, we know that drug-eluting stents reduce the rate of restenosis. And yet, in terms of death and myocardial infarction, we never saw any change in mortality until the ESC September 2006, when there was the stunning announcement that drug-eluting stents increased mortality and myocardial infarction. Now, who were the people at that point in time? Because I might add, the use of drug-eluting stents dropped almost 25% overnight based upon this. Now, at that time, in the early days of drug-eluting stents, who got the stents? Sicker patients with diffuse disease, diabetes, small vessels, complex lesions. They were sicker patients to begin with. Is that a surprise that there was a higher mortality with drug-eluting stents? And then what happened 2 or 3 years later? Same registry from Sweden, same journal, New England Journal. It's nice to publish 2 papers, 2 years apart with totally different results. And in 2007, 2008, drug-eluting stents now showed that they reduced mortality. And this is first generation, not the current. They actually reduced mortality. But at that point in time, who were the people that now got bare metal stents? Everybody got drug-eluting stents except sicker patients who couldn't take clopidogrel or couldn't afford it. They had more comorbidities. Non-cardiac surgery was planned, so they wanted a shorter period of antiplatelet therapy, and those with a higher bleeding risk. So now, no surprise, the two groups are different. The registry data are different. And it's easy now to understand. This group had a higher mortality with drug-eluting stents because they were sicker patients, and this group with bare metal stents were now the sicker patients. In fact, the bottom line was really this. There's no difference in mortality, maybe with the third generation stents, but there isn't any difference. This is an example of what a registry can tell us. And then there was the great ASSERT study, which was a combination of two huge databases in the United States, a PCI database and a CABG database. And in fact, the ASSERT trial was not a trial, it was just a study. And so if you look at 2 and 3 vessel disease, what do you see? Everything to the left of the line favors bypass surgery. So with 3 vessel disease, there was a clear benefit from bypass surgery, not surprisingly. But with 2 vessel disease, we now see a mortality difference in favor of bypass surgery. Never been shown before. And even in the early trials of bypass surgery and medical therapy in the 1980s, when there was no such thing as medical therapy, really. Basically, medical therapy was not having surgery. There was no great medical therapy. And even in those trials, those early trials of bypass surgery and medical therapy, we could not show a benefit for bypass surgery on mortality. And suddenly, in 2 vessel disease, and suddenly now we show that not only is bypass surgery better than, presumably medical therapy, it's better than PCI. This is purely and simply registry data comparing 2 completely different data sets, and I think in this case, drawing the wrong conclusion. So now, to come to the trials. The FREEDOM trial, you will know there was a benefit to surgery in death, MI, and stroke combined, and death from any cause, P less than 0.005, but the price to be paid was a higher rate of stroke in 2 and 5 years. Then comes the SYNTAX trial. I think this is a very important, very, very helpful trial. And these are the results at 5 years for patients with, let me just go up to the heading here, 3 vessel disease. If you look at MACE, and what this graph shows is let me just get this down here. What this graph shows on the x-axis is the SYNTAX score, 0 to 22, 22 to 32, and greater than 33. And if you look at the 2 highest terciles of SYNTAX score, there is a clear benefit for surgery over medical therapy, over PCI in MACE. All-cause death, again, in the intermediate and the highest tercile of SYNTAX score, mortality benefit for bypass surgery. For stroke, no statistically significant benefit, and for MI, exactly the same. So the conclusions are, in people with 3 vessel disease, with an intermediate or a high SYNTAX score, there is a benefit to surgery over PCI. All things being equal, surgery should be completed. But there's another point to be made. Fully 1/3 of patients with triple vessel disease, 1/3, did equally well with PCI compared to surgery. With left main disease, and you heard earlier today about this, the 5-year event rate is quite surprising. With a SYNTAX score of 0 to 32, which is low and intermediate, there's absolutely no difference in MACE in left main disease. And in the SYNTAX score greater than 33, there clearly is a benefit for surgery, shown here in yellow, at least in orange compared to PCI in yellow. This is the cumulative event rate. And this is now in the guidelines. The guidelines have actually said that in patients with a low to intermediate SYNTAX score and left main disease, bypass surgery or PCI is an equally reasonable option. Really, we have to wait for the EXCEL trial, 2,000 or 3,000 patients The trial results should be available next year. This is another fact. Obsolescence in trials of PCI and cabbage is a fact of life because of the evolution of PCI technologies, which change PCI-specific outcomes. So how do we deal with this in the guidelines? And how do we deal with this in the design of future trials? I mean, these trials are very difficult to do. They take 5, 6, 7 years to do it. And by the time you're finished, everyone says, no, I don't believe the trial because technology has moved on. It's a fact of life and it's very difficult. And when you sit on a guidelines committee, do you take a trial that's 5 years old, but you have to also try and adapt the data to changing technology, and it's difficult. And so the limitations of the published trials of coronary revascularization, all of these are good trials, but we have to realize that things have changed since they were published. We have better stents. We have better pharmacotherapy, especially antithrombotic therapy. None of these trials took into account some of the newer antiplatelet drugs. We're better at doing a PCI, and I think the role of fractional flow reserve is playing, to my mind, is a huge development. And that's not there in the trials. I will come to the residual syntax score in my next slide. PCI has performed better, the use of intravascular ultrasound. That wasn't there in these trials. And then a patient-centered approach to case selection, which may have a huge impact upon outcomes, how you select the patients, and that's not in the trials. But equally, surgery has changed. And this is Dr. Taggart's meta-analysis from 2001, bringing to our attention the importance of bilateral IMAs or bilateral IMA or IMA and radial compared to data with a single IMA. And if you look at this meta-analysis and you come down here to the pooled data, there's a 20% reduction in survival with bilateral arterial grafting. And this is a very recent Mayo paper of about 2,000, well, it's of about 10,000 patients, but we actually did a propensity analysis, and in this multivariate regression model, multiple arterial revascularization, that's multiple arterial versus one lemur and a saphenous vein graft shown up here, on multivariate analysis, multiple arterial revascularization reduced mortality by 21%. And the conclusion, the use of multiple arterial grafts is strongly associated with improved late survival. And the final conclusions are interesting. In patients with multivessel disease undergoing isolated cabbage with lemur to the LAD, bypassing the non-LAD territories with at least one additional graft, conferred a survival advantage through 15 years. So this is, if you compared a lemur with a saphenous vein versus a lemur and another arterial graft, survival advantage at 15 years. And then I think the second paragraph's interesting. The survival advantage increased with time, suggesting that the initial selection of conduits was a more important factor in survival than problems appearing late after surgery, such as coronary disease progression. And I think important affirmation, now this is a registry, it's not a trial, that bilateral arterial grafts are the superior form of coronary bypass surgery, and that's not in the trials, and we have to live with that. And then this meta-analysis from Bangalore, a network meta-analysis of 68 trials, 24,000 diabetic patients. This is how they did the network. But what is important is the comparison of plain old balloon angioplasty versus bypass surgery, sirolimus stents, taxus stents, and right here you've got cobalt chromium everolimus eluting stents versus bypass surgery. Everything to the right favors PCI, everything to the left, I mean the other way around, everything to the left favors surgery. And what you see is the benefits of surgery shown here. This should be favors cabbage, not PCI. The benefits of surgery start to fall away with the latest stent technology. This is not a randomized trial. This is a registry study. But it's something that you have to think about when you sit on a guidelines committee. How do you take the trials that we have and adapt the results to the new technology? Now, this is about the residual syntax score, which is to calculate ahead of time what the syntax score will be after you've done PCI. The residual syntax score was shown to be a powerful indicator of 5-year mortality in the syntax trial. And the residual syntax score may aid in determining a reasonable level of revascularization. So times are changing, and our traditional methods of selection really have changed. And I think this is actually clinically very useful, because you can sit there ahead of time and say, well, if I do PCI, this is what I'm going to leave behind in terms of disease. And that may make you change your opinion in terms of selecting bypass surgery instead of PCI. What about the impact of FFR? This is a very nice French registry from Eric van Bell. And what it's shown here is these are the people that the original strategy was medical therapy, then PCI, then bypass surgery, medical in green, PCI in orange, and cabbage in yellow. And then after FFR, how the strategy changed. And you'll see that in those in which whom medical therapy was planned, after FFR, only 67% of them were treated medically, and the others went to revascularization. In those in which bypass surgery was planned, a significant number of them after FFR went to PCI, and in those in whom PCI was planned, a significant number, smaller number went to surgery. So how FFR is going to impact our practice, I think it is going to do so in a great way, to a marked extent. This is a very, very interesting paper by Tocchetti, measuring coronary flow reserve. And what this shows is the event rate on this axis in patients with high coronary flow reserve, not revascularized, high coronary flow reserve with PCI, and high coronary flow reserve with cabbage. Although the event rate seems to be reduced with PCI and bypass surgery, it is not statistically significant. But what about those with low coronary flow reserve, which is a marker of very diffuse disease, including the microvasculature? And now what we see is a huge difference in event rate in patients undergoing surgery versus PCI or no therapy at all. And this may be something, again, that we will in the future integrate into our practice, because this comes back to my original diagram, and that is that PCI addresses a lesion or lesions, but it doesn't address the whole vessel, which surgery does to some extent, not the microvasculature, but the whole vessel. And finally, I think Patrick Seroysen has really tried to do something that's very good, and that is develop the Syntax 2 score, which integrates the anatomical data with the clinical data. And this is the effect of the Syntax 2 score on mortality, and it's very striking. It's also very complex, and I won't go into it in any detail at all, but there are a number of factors that have to be taken into account. Age, creatinine clearance, ejection fraction, left main, sex, chronic pulmonary disease, peripheral vascular disease, and you go down and you draw a line down and you calculate the score for cabbage and PCI, and it'll give you an estimated effect of the benefit of the survival with one procedure versus another. So to conclude, in patients with multivessel disease and stable angina, I think bypass surgery is still the procedure of choice for most people with 3-vessel disease who have a high and intermediate syntax score. What is really important is the role of comorbidities. That's not in the syntax score. That's extremely important. PCI, bypass surgery for the majority with left main disease, for the majority of CTOs of major vessels, especially the LAD, and those with diffuse disease. The left main disease, we'll see. But really, again, what is important now is to move away from the anatomy and look at the patient. PCI, still the best form of treatment for 2-vessel, preserved LV function, advanced age and comorbidities, suitable anatomy. Those were the patients in the trials, and the changing indications are really these. 3-vessel disease, low syntax score, good candidate for PCI. Left main disease, we will see more in the future. LV dysfunction, mainly a surgical disease, but more and more being done with percutaneously. And diabetics, you simply have to individualize. Thank you for your attention.